Hello everyone. I'll be continuing my discussion about the disease of the small intestine, and again I'll be giving you an integrated approach covering all these subspecialties which are relevant to my talk. The first topic is about carcinoid syndrome. It's a very important topic. It's a part of neuroendocrine tumor. Okay. So it's a most common small bowel malignancy. Point to be noted, this is a malignancy that we cover under a category of small bowel. Of course, there is a clause is there about which that I am going to discuss in a minute only. However, I told you is a neuroendocrine tumor. So whenever we talk about neuroendocrine tumor, that means this tumor is going to secrete certain biochemical, maybe a hormone or any biochemical material will come, and that's what we call as endocrine tumor. Okay. Now, the most commonly in the small gut, mid gut, at the level of ileum. So that's why I told you it's a disease of primarily of the small intestine. Mid gut consists of small intestine if you go by embryologically. Or you can say about 75 to 80% cases are in the small gut or mid gut lesion only. Okay, so that's why the commonest site is mid gut. And they are, if you talk about pathology, they are the part of epidermis. Now, what do you mean by epidermis? They arise from the enterochromaffin cells throughout the gut. I'll be talking more about these cells. So as of now, what are the keywords that you got to remember in this? The first and the most important is neuroendocrine tumor. Second is mid-gut, most common site. And third keyword is they are the part of epidermis. So there are only three keywords to be noted in this particular slide. Right? So after that, we go into more detail about epidermis. All carcinoid have a malignant potential. Point to be noted. That's why they are considered in the category of malignant tumors, right? Why? Because they can have metastasis also. Now we have a term called epid. This stands for amine. A for amine, P for precursor, U for uptake, and D carboxylation. This is a part of biochemistry. Point to be noted, they are located outside the endocrine gland. They have an endocrine function, but they are not lying in any of the endocrine gland. They are lying outside the endocrine gland and usually in the epithelia, some epithelium. And now if you go back to previous slide, enterochromaffin cell throughout the gut. This is a fourth keyword which I deliberately avoided to tell you. Just I wanted to correlate with the pathology that they are in the GIT. Throughout the gut. Let's discuss this word throughout. Unlike a proper endocrine gland like pituitary, thyroid, or any gland, they have a localized area where these cells are located, but they are throughout the gut. Even if you talk about small intestine, is a huge, about 10 or 12 feet long. So there is nothing like a localized gland is there. So this is a fourth keyword. So now you understood they lie outside the endocrine gland And the cell I told you in the previous slide, enterochromaffin cells are there. So friends, in this we just talked about what the meaning of APUD, and I'll be talking more about this biochemistry in detail, but at the moment I just told you what do you mean by APUD. Outside the endocrine gland, usually in the epithelia. So the first keyword is this and second keyword is outside the gland in the epithelial cell. Now the site of tumors. Most common site is appendix. Okay. In around 40% cases the site is in the appendix, and it is this one which can have metastasis to liver. Definitely, because the blood supply, whatever is getting drained, venous supply is going from this part is going to the liver. And in fact, carcinoid are the most common malignant tumor of the appendix. Anyway, the only keyword that what I want you to remember is appendix is the most common site. Just you have to remember this particular one keyword, that most common site is appendix. So now we look a lovely picture. We are getting a appendix and we are getting this, which is a yellow mass. Point to be noted. A yellow mass tumor is there in the appendix, and we can also see fecal material in the appendix. But only thing, there's nothing special. I just wanted to show you how they look like. They're yellow color. Okay. Now come the small bowel, 20%. Right. So remember the commonest site is mid gut, and in this most common is terminal ileum, and they also can go to liver. Point to be noted, the appendix is around 40%. The terminal ileum is around 20%. They constitute about 60%. Both of them, they go to liver. It has a special meaning that they go to liver, they go to liver. What the meaning I'm going to discuss in a couple of minutes. So now, in the above location, that is appendix and the terminal ileum, they produce bioactive compound serotonin. So in the basic biochemistry I told you, these are certain cells which are outside the endocrine gland, but they have a function like endocrine gland because they secrete any biochemical material, and the now come the what is the molecule? Serotonin is the molecule which they secrete. Okay, and the terminal ileum was the first keyword. Second keyword is serotonin. Now the point what I'm going to discuss, there are one point which is not known to 99% student. What is that? Golden line, gold medal line is there. So what just now we learned that it produces serotonin. So whether it is appendix or it is small intestine, it goes to liver via portal vein, definitely. And that goes into the liver sinusites. Now, in the liver, this is the liver cells. These are the liver cells. Liver cells. And this is the sinusoid. That capillaries which contain the blood. Finally, the serotonin S has come to the liver via portal vein, and ultimately it comes to sinusoid, which I don't need to repeat the anatomy again. So it has come to the liver. Now these hepatocytes, they will take up this serotonin. So this serotonin will be taken up by the hepatocyte. So they are now in the hepatocyte, they are metabolized into 5-HIAA. The full form is 5-hydroxy-indole acetic acid. Whenever the exam they will talk about 5-hydroxy-indole acetic acid, they will always write 5-HIAA. So just remember 5-HIAA. So in the liver, 5-HIAA is being produced from the serotonin. Agreed? Now this goes out of in the urine. It means what? Clinical applied. If you have to test for the carcinoid, you will check the urine sample. Yes. In the urine, which molecule you like to look for? 5-HIAA. So now you learn the basic biochemistry why we are going to check 5-HIAA in the urine. But there are many more important points. And now come the gold medal, the point what I told you, not known to 99%. This serotonin is completely metabolized. This conversion is 100% conversion is there. So completely serotonin is converted into 5-HIAA, and thereby it does not enter the systemic circulation. Rank number 1 question, not known to 99%. Point to be noted, the common site is small intestine, terminal ileum and appendix, which constitute about 60 to 70% cases. From there, the blood is drained by the portal vein and they come to the liver and it totally metabolized. So no sign symptom. No sign symptom. Shocking. Not known to 99, but now you are very happy that something gold medal line has been told to you. Okay. Well, other places are esophagus, stomach, colon, they are around 10%. So far, so good. Site, terminal ileum, appendix, serotonin has come but no symptom. Okay. So now we talked about, again I talked to you regarding metastasis can occur from terminal ileum and appendix. Let's talk about metastasis now. Point to be noted, so far I discussed about the serotonin going via portal vein to the liver. Now metastasis means the cell itself is going to the liver. Okay. So now metastatic potential, this is based on size and depth. Size more than 2 centimeter only, they go for metastasis. That means suppose there is one tumor in the appendix, but size is maybe only 1 centimeter. Then chances of metastasis are very, very low. Similarly, depth of invasion, that means 50% of the bowel wall or appendix wall should be there. So size and depth matters a lot, especially size. So the key word is size should be more than 2 centimeter before it can go into metastasis. So only one keyword, size, and the keyword here is completely metabolized and no sign symptom. So there are only 2 keywords and one is here. Agreed. But point to be noted, so far no sign symptom has come. Let us see what happened. Okay. Well, we have a foregut, stomach and hindgut rectum carcinoid. They invade, but they rarely metastasize. They may invade the wall of the stomach or the rectum, but they rarely have metastasis. Point to be noted, metastasis come from appendix and terminal ileum. Midgut, what I told you, they invade and metastasize. So now you understand the meaning of this line, that it should invade, size, and metastasis is done only by the two, that is midgut, that is small intestine, or the appendix. I hope that the pathology is clear. With this background, now we move on to pathophysiology. Most of the time, as I told you, if the patient, the tumor is in the terminal ileum or the appendix, it is totally asymptomatic. Why? The serotonin was metabolized in the liver and no problem. Okay. So this serotonin is cleared by the liver, no symptom occurs. And now the second scenario where metastasis has occurred. Let's see what happened. So now if liver metastasis, now the tumor itself has gone to the liver. Previously it has sent his messenger, and the name of messenger was, let's learn day to day. This is the appendix or a terminal ileum. Let's say this is a terminal ileum. And here the liver. And here is the terminal ileum. It has a carcinoid. It secretes serotonin. Serotonin is taken by the portal vein and has come to the liver. It has broken down into 5-HIEA. 5-HIEA broken down. But now the metastasis means liver, intestine, and carcinoid tumor, and the carcinoid itself has come to the liver. So now the messenger has not come. Okay, you can say in a lighter way. Initially he sent an email. And now email has produced no symptom. It was simply discarded as a 5-HIA in the urine, no symptom. And now the carcinoid got annoyed. Oh, no symptom, no problem. Now I myself will come. Okay. So this gentleman goes to metastasis. Of course, no need to say, it will again, now tumor cell itself go via portal vein, and now metastasis has occurred to the liver. Now the scenario is different. That's why I spent enough time. So now the serotonin, the tumor cell itself has reached the liver, and now again here it is due to the same, it will produce serotonin. Now this serotonin will be definitely entering into the hepatic vein. Hepatic vein will enter into inferior vena cava. It means what? This serotonin has entered into systemic circulation. Systemic circulation, now it has entered. So it is this which is going to produce symptom, right? So point to be noted, if the tumor is confined to appendix or small intestine, will not produce any symptom. Symptom will be done by only metastasis. Okay. So now it has entered the systemic circulation and now it's going to produce the symptom. So friends, the key word are those which, when the serotonin goes to liver, cleared, but if the metastasis, they will produce the symptom, right? The metastasis, so two keywords are no metastasis, no symptom. Metastasis, symptom. So you can write down no mets, no symptom. METS means metastasis, no symptom. METS, symptom plus. So this is the summary of the two previous slide, this slide and the previous slide. No METS, no symptom, METS plus, symptom plus. Right? So simple to remember. Now, let us see what are the carcinoid syndrome symptoms. So now we are clear about it. The metastasis which is going to produce symptom I discuss. Right? And now one thing more. Now again gold medal line. What I told you, the site of origin is either ileum or carcin or the appendix. But there are 10% cases which may arise outside other places. In the 10% there is one place called bronchus. Rarely it can arise in the bronchus. In the bronchus, serotonin will be produced and it will enter the systemic circulation. So bronchus carcinoid will also have features, but it is an uncommon place. But people do, invariably the question is asked about this also. So now symptom will be produced by liver mets, bronchus without mets. In bronchus without mets, that means bronchus itself can secrete because it's going to systemic circulation. The main thing is the serotonin should go into systemic circulation. So this is a key word that you got to remember in this particular slide. So we learned about various things that problem is due to serotonin. So serotonin is the main compound, but if it is coming from bronchus, then it may secrete certain other compound like histamine and bradykinin only. But this usually occurs when it comes only from the bronchus. It was additional knowledge which I wanted to share with you. But by and large, for all exam purposes, the key word to remember here is only serotonin. Now, what happened? What are the feature we like to have? That flushing of the skin. Skin flushing is a very important. Okay. This is due to why this happened. Flushing. He feel hot, all due to vasodilatation. So definitely, if vasodilatation will occur, so that will lead to more and more blood flow, increased blood flow into that particular area. And if blood flow more and more, the person will feel hot also. And it is triggered by emotion, alcohol and other food also. In particularly alcohol. So alcohol causes more triggering effect. It is just adding fuel to the fire. So definitely alcohol is going to precipitate now the clinical applied is these patients should not take alcohol. So when we treat the patient, we say don't take alcohol, otherwise it's going to create more and more problem. Syncope due to low BP. Why? Vasodilatation. This will this will reduce peripheral resistance. If the peripheral resistance goes down, the BP will go low, a patient may have syncopal attack. Diarrhea, because increased GIT motility by the serotonin. So it means if I have to tell you only two keywords to be remembered in this, one is the keyword that you got to remember. First keyword is vasodilatation. Second keyword is diarrhea. That's all. With vasodilatation, you can explain flushing in the face. You can explain hypotension, and with increased GIT motility will lead to diarrhea. Okay. So now this you can see some flushing of the face and upper neck area. Intermittent wheezing and dyspnea. This will happen only when the problem is in the lungs. Lungs problem will lead to this. The patient can have intermittent wheezing and dyspnea can be there. But point to be noted, in the lungs there is the release of histamine also. And we are well aware that histamine is a very potent vasoconstrictor in the lungs. Facial telangiectasia, that is dilatation of the capillaries, that we can explain by the vasodilatation. Now, again come the gold medal question, very frequently asked question. These patients can develop tricuspid regurgitation and pulmonary stenosis. Very, very important question. Very frequently asked question. They can develop tricuspid regurgitation. Okay, tricuspid regurgitation, and they can develop pulmonary stenosis in due course of time. Why? What is the basic pathophysiology? Serotonin increases collagen production in the valves. So definitely long-standing and especially on the right side of the valvular heart disease, because ultimately inferior vena cava is draining into right atrium, which is going the blood into right ventricle. So tricuspid regurgitation and pulmonary stenosis are two common findings which are seen in these patients. Very frequently asked question, is a FAQ type of question, very important question. Well, one more, the outflow of serotonin lead to depletion of the tryptophan, and we know very well it's that lead to niacin deficiency, and that will produce pellagra. I'll show you the biochemistry, then let me show you the biochemistry first. So let's learn the biochemistry of the entire so-called carcinoid syndrome. So we have a carcinoid cell, we have a tryptophan. So in the biochemistry part of the story, and this will make serotonin, tryptophan, and this is stored in the granules, tryptophan. So in carcinoid syndrome, large amount of tryptophan will be converted into serotonin. Now this is stored in the blood, now it is secreted into the blood, right? Remember, this 5-HT serotonin is in the blood, and in the blood some amount is taken up by the platelets. We are all well aware that serotonin is there in the platelet also, and after that it comes to the liver. In the liver it is broken down into 5-HIAA, and that goes out in the urine, filtered in the urine. The patient had no symptom at all, right? Well, 5-HT can be little bit filtered in the kidney also. Normal level is typical, and sometimes the level is very, very high. Level is very, very high, and that serotonin is 1. That means the level of even serotonin is very high. That again indicate it's an abnormal finding. But remember, this serotonin will come only from those serotonin which has been secreted by the liver metastasis. Because if it is from the appendix or terminal ileum, serotonin will not be there. So increase 5-HIAA and increased serotonin level are the classical finding that we expect in a case of carcinoid syndrome. So if you want, I can give you a full screen picture. You can see, if you want to note it down, maybe I just enlarge step by step. Step by step, you can see this. You can write down this much. Write down this much. And write down this much. Okay. So we learned the biochemistry. So we are quite comfortable. Right, sir. Well, we also know the biochemistry that it's a tryptophan which makes niacin. Now the whole tryptophan has been to make diverted to make serotonin. Tryptophan, serotonin, niacin, normal. Tryptophan, serotonin and niacin. Agreed? This is normal. But here the problem is this is much more. It is much more. So definitely large amount of tryptophan has been diverted towards serotonin. The amount of which going to our niacin will be reduced. It is increased. So there will be deficiency of niacin. Right? So you understood the basic concept why there will be deficiency of niacin, because the tryptophan has been diverted toward the serotonin. Right? I can give you a day-to-day example. We have politicians and funds come for the welfare of the country. The money should go to public welfare. But as usual, majority of the politicians, they siphon the money for the self. So the amount of money which was supposed to go for welfare goes to self, and the result, money meant for welfare doesn't come to the public, and things remain bad and they become worse despite government spending so much of money. Same thing, the tryptophan diverted towards serotonin, deficiency of niacin, and that into pellagra. Pellagra is 3D dermatitis, dementia and diarrhea. This dermatitis you can see mainly in the sun exposed part. Dementia, it's a cause of reversible dementia. Point to note it, reversible dementia is there. Diarrhea. Okay. So now investigation, now it is very easy for you. What we do? We check for 5-HIAA, is a metabolite of serotonin, no need to explain. In case is diagnostic. But point to be noted, again a rank number 1 question. Bananas, pineapple and walnuts, they falsely elevate level of urine 5-HIAA. Okay. The point to be noted that patient should not have taken these things, banana, pineapple or walnut, for at least 3 or 4 days before you really check for 5-HIAA level. CT scan is done to locate the tumor, and we must do echocardiography to rule out any valvular lesion, TR and pulmonary stenosis. A radio level octotide scanning is done again to locate the tumor. Okay. So this you can see CT scan showing a tumor. And here is octoscan, nicely depicting. That's why octoscan is always considered as a better modality to look for the metastasis. Treatment: avoid alcohol, stress, no need to repeat because they all exhibit the symptom of carcinoid. Surgical resection is the main treatment. It's a main treatment. But at time is not able to locate or cannot already it has been total metastasis, then we can go for chemotherapy. In chemotherapy, we go for octreotide. This is especially effective in controlling diarrhea and flushing. Definite treatment is surgery. But surgery cannot be done in 1 or 2 hours or 1 or 2 days. It needs some preparation. But patient has a lot of symptom of diarrhea and flushing. You give octreotide. It is really going to control the symptom. A new drug has come, trilotristat is a recently introduced drug. So, where we give this drug? So, we have a patient to whom we have proven that he has a carcinoid. The first line treatment is always octreotide, the way I mentioned. But it is poorly controlled. Despite giving octreotide, the patient's symptom then you can add telotristat. So it is a add-on therapy to octreotide. The first line treatment is always octreotide, and if it doesn't work, then you can add on to telotristat. You continue with octreotide. These two are good for symptomatic relief. Definite treatment occur only by surgery. And let's learn a little bit of biochemistry of telotristat also. It inhibits tryptophan hydroxylase. So, tryptophan is converted into 5-HTP by the enzyme tryptophan hydroxylase, and this drug inhibits this enzyme. So remember, it inhibits serotonin synthesis. So it inhibits enzyme tryptophan hydroxylase, basic biochemistry. I can enlarge the view so that you can write it better. So a quick recap of the last minute revision point. It is a neuroendocrine tumor. Most common site is appendix. Malignant, secrete serotonin, diarrhea, flushing, wheezing, abdominal cramps, TR and tricuspid regurgitation and pulmonary stenosis. Best initial test is RAISE 5 HIAA. Surgery is the only curative therapy. Chemotherapy is for symptomatic treatment. Golden line to remember. Patient present with pellagra, asthma, diarrhea or syncope. This is carcinoid. P for pellagra, A for asthma, D for diarrhea, S for syncope. PETS is carcinoid. Friends, whole carcinoid is squeezed only in one word. PETS is carcinoid. Your any exam in the world you write, you can answer question based on this simple. PETS is equal to carcinoid. You can revise whole carcinoid only in 1 second. PETS, carcinoids. Lipoma. It is also known as Werner-Morrison syndrome. It is also known as pancreatic cholera. All are one and the same thing, right? So what is this? It is a non-alpha, non-beta cell pancreatic tumor that secrete VIP. VIP is vasoactive peptide. Highly malignant tumor is this. So before I talk about the lipoma, let's discuss the basic physiology, basic concept about VIP. Vasoactive intestinal polypeptide, VIP. Source, parasympathetic ganglia in sphincter, gallbladder and small intestine. Okay. What is normal action of VIP? It increases intestinal water and electrolyte secretion, and it relaxes the intestinal mucosa and the sphincter, right? So there are two keywords as of now. It causes secretion of the water and electrolyte. This is the single most important word that you got to remember. So friends, this is the normal intestinal cells, and here is the lumen. They are cells. This is the lumen of the intestine, and normally it secretes water and electrolyte. Normally. So now do I need to tell you that if the VIP is in excess, of course everything is in well controlled manner what we have. Okay, well controlled manner. Now if excess of VIP is there, it will lead to what? Excess of water and electrolyte will come to the intestine. So what do you think? What type of diarrhea it will be? It will be type of secretory diarrhea. Why? VIP is throwing large amount of water electrolyte into the lumen. Okay. So they are so now you understood why this patient will likely to have diarrhea, because secretion, and you will get secretory diarrhea in this case. And how they are regulated? By abdominal distension and vagal stimulation. Vagus has a control. We are all well aware that vagus is a parasympathetic for the large part of the intestine, and it is reduced by adrenogenic input. So definitely vagus will increase and adrenogenic will reduce. They have antagonist action. So now you understood vagus is going to increase secretion. Okay. What are the clinical feature we are going to have? Watery diarrhea. Why watery diarrhea? Because water is being secreted into the lumen. Hypokalemia. Why? Definitely large amount of sodium chloride is getting lost. Body will try to absorb more and more sodium. More sodium will be absorbed into the nephron. Body will try to absorb more and more sodium. Sodium will be absorbed, and that lead to loss of potassium. The potassium will be lost and hypokalemia. In fact, this is the most important word. Is the one which can lead to severe hypokalemic dehydration. Achlorhydria, because gastrin secretion is inhibited by VIP. So VIP inhibit gastrin, so that lead to achlorhydria. So what we call as VADA syndrome. WDHE. Watery diarrhea, hypokalemia and achlorhydria. The classical triad of so-called lipoma or lipoma. Dehydration, I don't think I need to explain. Muscle weakness, why? Why? Because the patient has already lost large amount of electrolytes. So to examine the stool, osmotic gap is reduced. It is a type of secretory diarrhea which I already explained to you what is the basic mechanism of secretory diarrhea in these patients. Hypokalemia, we understood. High VIP level, yes, that's a basic pathology. And normal anion gap metabolic acidosis. Because large amount of bicarbonate is lost in the uric in the stool, that is the feature of all diarrheas. CT scan is done to localize the tumor. So the key word is secretory diarrhea and hypokalemia, high level of VIP, and normal anion gap metabolic acidosis, so-called hyperchloremic metabolic acidosis, so-called hyperchloremic metabolic acidosis will be there. Treatment, the first aim of treatment is always correct dehydration. Simple, any diarrhea patient come, irrespective of whatever reason it may be. Our first aim is always to look for the hydration with ORS or IV fluid depending on how much dehydration. Then to control the diarrhea, we give octreotide. It is somatostatin analog. It blocks the action of VIP. Okay. Ultimately, we remove surgery. Okay. So here also we have to remove the source of tumor, that is hormone is VIP. You go for surgery. So the quick recap, the treatment is octreotide or surgery. Only two keywords are there to learn in this particular slide. Now the new thing has come recently, recent advances. For the metastatic disease, we go for PRRT therapy. What is this? It is peptide receptor radionucleotide therapy. Peptide receptor radionucleotide therapy. What we do? We give lutetium 177 or yttrium 90 and it is attached to octreotide. It is, so we got octreotide. This is octreotide, O for octreotide. To this, we attach lutetium 177 or yttrium 90. Any one of them is attached to the octreotide molecule. So now octreotide molecule is carrying a radionucleotide particle. And we just read now that it is going to reduce the release of VIP from the vipoma. So it will get attached to the vipoma and these nucleotide, okay, they are going to, now they have reached the site where we want they should reach and this is going to destroy that particular tumor. Okay. So friends, golden line to remember: watery diarrhea, hypokalemia, achlorhydria is vipoma or pancreatic cholera. In your exam question, invariably this will be surely there. Watery diarrhea will be there. And he might even say that on investigation, patient has achlorhydria, that's all. So this WADA syndrome is good enough to know about. Or he can say this way, it resemble like cholera. But remember, in cholera, he will use it resemble like so cholera. We have a rice water stool. But in pancreatic cholera, what we call as vipoma, it is a not rice water. Point to be noted. Although both are secretory diarrhea, but stool appearance will differ. But rice water comes, you are 100% you are dealing with cholera. Okay, so this was regarding vipoma. We have one more neuroendocrine tumor is somatostatinoma. They are rare pancreatic islet cell malignant tumor, and that arises from the delta cells. Point to be noted. So the keyword is delta cell, of course, of the pancreas, but only one word keyword delta cell. So let's read more anatomy and physiology of the endocrine pancreatic cell physiology. Most of everyone knows that in the pancreatic islet cell there are alpha cells, there are beta cells, everybody knows, but some of us are not aware that there is something called delta cells also. Okay, alpha cells secrete glucagon, beta cell insulin, and delta somatostatin. But what is the location of this? Look into this diagram. Alpha cells which secrete glucagon, they lie in the periphery. Look into this. All pink, pink, pink. Then beta cell, yellow, they are inside. The delta cell like this, they and this, they are spread. They are spread. Interspread are there. The point to be noted is, but anyway, what we are concerned is delta cell which secrete somatostatin. With this background of anatomy and physiology, let's talk more about physiology of somatostatin. Physiology of somatostatin. Well, in fact, initially the somatostatin was the term we use for the hormone from pituitary. Let's discuss basic. We know very well that we have a growth hormone which comes from the pituitary gland. Pituitary gland. We also know that from the hypothalamus, H for hypothalamus, growth hormone releasing factor, growth hormone releasing inhibitory factor. So growth hormone releasing and inhibitory factor, they were there. So what I always say, there was an accelerator and there was a brake, which by this the growth hormone is under control. And this is known as somatostatin. The other name of growth hormone releasing inhibitory factor is somatostatin. So the confusion lies here. Every student think that somatostatin is coming from hypothalamus which control growth hormone. But later on it was found that this somatostatin, not only it comes from hypothalamus, it is also secreted from many other places like pancreatic islet cell, GIT mucosa, especially these cells. So this can come from other than the hypothalamus. So D cell in the pancreatic islet cell tumor, even gastric mucosa also it can come. This is about somatostatin. What is the normal physiological action of this. Okay, regarding the growth hormone, I told you. So at the moment, I'll talk what is relevant to my talk. It decreases gastrin, it reduces gastric acid and pepsinogen secretion. Alright, because they act via parietal cells. They also decrease pancreatic and small intestine secretion, like reduce secretin and reduce cholecystokinin. Fine. So definitely they are going to hamper the pancreatic function also. They reduce gallbladder contraction. So that means they are going to cause stasis of the bile in the gallbladder. And very interestingly, it reduces glucagon and insulin. Something very interesting to talk. Let's go back. Well, we learned about delta cell. We are talking about delta cell, which secretes somatostatin. Alpha secrete cell, they secrete glucagon, G for glucagon, and beta cell, they secrete insulin, glucagon and insulin. Now, this is secreting somatostatin S. Now, this S, which is somatostatin, it will go and inhibit, reduce glucagon and reduce insulin. So this somatostatin is going to reduce insulin and glucagon both. If both are getting reduced, so definitely something is going to happen to glucose level. What happened? That I'll discuss in a minute only. But as of now, we just learned the delta cell, which is again a part of islet cell. It reduces the secretion of its two fellow friends, alpha and beta. It reduces the level of both. Okay. So with this background, now how it is regulated? It's increased by increased acid and decreased by the vagal stimulation. Basic physiology. Now we learned about somatostatin. So before I really go to the topic of somatostatinoma, let me cover the clinical applied about the uses of somatostatin, so-called octreotide. Octreotide is a analog. Analog means is the synthetic form of naturally occurring molecule is somatostatin. So we use in acromegaly. Reason I told you, because it is going to inhibit the growth hormone. It is used in carcinoid syndrome. I discuss gastrinoma, glucagonoma, esophageal varices, and vipoma. They are the uses. This is a very important slide. In your exam, you'll be definitely getting one question from this slide. Octreotide is one of the most widely asked topics throughout the world. This is a ranked number one getting slide or very frequently asked question. This you should know. Uses of somatostatin. With this background, now we move on to our topic of discussion is somatostatinoma. It's a very rare tumor, solitary large tumor, more than 2 centimeters size. Rare but big size. Mostly in the head of pancreas. Point to be noted. Head of pancreas. Malignant, and they may be associated with neurofibromatosis. Anyway, as of now, the only keyword to remember is 2 centimeter size, and they are very malignant tumor. Only two keywords. The clinical features. They may present with hyperglycemia or hypoglycemia. Any idea why? Just a minute back I told you somatostatin can reduce both glucagon as well as insulin secretion. Both are reduced. It will lead to steatorrhea or gallbladder stones. So now I'll take one by one. But this the summary. This you should note down. Hyper or hypoglycemia, steatorrhea and gallbladder stones. Let me discuss in detail one by one. Regarding gallbladder stones, in the basic physiology I told you, it reduces gallbladder contractility. How come? This inhibits release of cholecystokinin. You remember, the cholecystokinin is reduced, and even pancreatic juice, cholecystokinin and secretin are reduced. So, cholecystokinin is the one which also lead to gallbladder contractility. Is not there. So, poor gallbladder contractility, and that lead to stasis of the bile into the gallbladder, and that precipitate gallbladder stones. Decreases glucagon. Number 2 was regarding hyper and hypoglycemia. It reduces glucagon as well as insulin, the point I mentioned to you. Okay. But it reduces insulin much more than the glucagon. So, this the glucagon, this is insulin, glucagon level is reduced, but insulin level is reduced much more than this. So now, in nutshell, level of glucagon will be more than the insulin level of glucagon. So definitely glucagon is more. So that lead to what? Hyperglycemia is more likely to occur. But not in 100% cases glucagon will be less. It can be other way around also. Glucagon suppression may be more, then in that cases hypoglycemia will be there. Now, why steatorrhea occurs? Decreased secretin is there and decreased cholecystokinin, and that lead to reduced GIT mortality. Okay, right? So that's why ultimately secretin is not there. And second thing that will contribute the problem is fat digestion will be impaired. Fat will not be digested, and that lead to steatorrhea. So it's a steatorrhea that will lead to a type of loose motion or diarrhea, right? So steatorrhea is going to happen because fat is not getting digested, and there is decrease in the gastrin release. This leads to hypochlorhydria. That's the reason why hypochlorhydria occur in these patients. Treatment is again surgery, and sometimes we can use streptozocin, but they are all supportive treatment. Main treatment is surgery. LMRP, somatostatin physiology from the delta cells. Decreased secretion of secretin, cholecystokinin, glucagon, insulin and gastrin. Hyper or hypoglycemia, steatorrhea, gallstone, and treatment is surgery. Golden line to remember: hyper or hypoglycemia, steatorrhea and gallstone. If you are getting these three, you are dealing with somatostatinoma, right? So the next topic is protein losing enteropathy. There are certain conditions where the GIT tend to lose albumin and globulin. Protein are lost. Point to be noted is a total protein is lost including albumin and the globulin. So what are the diseases which produce protein losing enteropathy? Point to be noted, protein is being lost from the GIT. So let us see causes. In the stomach, it is a Mentrier disease. We have read that there are lots of folds are there in Mentrier disease, and that causes protein losing enteropathy. For detail, you can see my lecture on Mentrier disease. Intestinal lymphangiectasia. The lymphatics in the intestine are blocked, so lot of protein losing enteropathy occurs. Inflammatory disease of the GIT, inflammatory bowel disease like ulcerative colitis and Crohn's disease. Parasitic infection, and this may even occur in the blind loop syndrome, about which I am going to talk little later on. Okay, so there is nothing to explain to you. These are all factual things that you got to remember. But in this, don't forget Mentrier disease. Single one word you should remember. Tumors, gastric, small intestine, colonic, any tumor, nothing special. Other disease, celiac, tropical sprue, radiation, enteritis, Whipple, nothing. But one thing you should never, never, never forget, constrictive pericarditis. Rank number one question. You forget everything, any other cause, I don't mind. I don't mind. But don't forget this. Say it is so important. So I like to throw more light. I have discussed in much more detail in my lecture on constrictive pericarditis. However, I like to add few lines. Of course, I'm not going to teach you cardiology right now. In constrictive pericarditis, it's clinically, it resembles like cirrhosis of liver. Clinically. Okay. In these patients also there is massive ascites is there. Even spleen may be enlarged and they lead to protein losing enteropathy. So this is the one which is the DD of cirrhosis of liver. There is ascites, there is splenomegaly, and there is protein losing enteropathy. Very, very important question. Well, the clinical feature, I don't think I need to tell you. If the body has deficient albumin, the patient will come with edema and generalized anasarca. There may be steatorrhea due to lymphatic blockage in some of the cases, not in all the cases. How we diagnose? Again, not known to most of students. This is so-called radioactive alpha-1 antitrypsin clearance in the stool. Radioactive alpha-1 antitrypsin clearance. Alpha-1 antitrypsin is resistant to degradation by the digestive enzyme. Well, it's a type of protein, but this is not getting digested by the enzymes. So, it is an endogenous marker for presence of blood protein in the intestinal tract, right? So of course, ultimately it has to come from this, whatever protein is getting lost, it has to come from the blood vessel. So now this will enter the GIT, and that you can detect in the stool. Okay, that you can detect in the stool very clearly. So if you are getting radioactive alpha 1 trypsin in the stool, that means it is getting leaked out from the blood vessel, and that confirm protein losing enteropathy. Treatment is always treat the underlying cause, whatever it is. Short bowel syndrome. Before I really go into the topic, let me tell you some basic concept. Mouth is the entry for the food. Stomach for storage and mixing of the food. Stomach. Small intestine, digestion, absorption of the food. Large intestine, mainly for water and electrolyte reabsorption. This is a very crude outline of the function of various parts of the GIT. Very simple. When we talk about short bowel syndrome, in the short bowel, and again remember, out of these all, longest is small. This is the most long. In our, if you remember your college days, when you do the dissection of the anatomy of the abdomen, you always take out the intestine and you always try to measure. And I'm sure you all must have measured the length of the small intestine. God is the greatest engineer. Why? God knows that small intestine has to do the most important function. That means the food has to be broken down into small particles, digestion. Then it has to be absorbed also. And that is all a very slow process, not a very fast process. So that's why God has made a very long intestine, 10, 12, 13 feet long. Now let's say for easy calculation it is 10 feet. 10 feet is there. And due to any reason a part of the intestine has been removed, now only 5 feet is left. 5 feet has been removed due to any reason, maybe some surgery was done. So now a very small quantity of the intestine is left. Definitely workload is very high. The manpower in the form of intestine is very less. So now what will happen? Incomplete work. Digestion will not be proper and absorption will not be proper. That is short bowel syndrome. So I have given you the basic concept. With this we move into the actual content. So now my things are very easy. Reduction in the absorptive area of the intestine. How come? You have removed a part of the small intestine. So definitely the area of absorption is reduced. And this is usually done by surgical method. Sometimes it could be functional reduction also. Condition I'll talk a little later on. But in actual practice, majority of time we talk surgical removal is there. So many conditions are there. Okay. So now come a definite exam question. What is the actual meaning? The 10 or 12 or 13 feet intestine is there. So when you will say, when the functional small intestine size is less than 200 centimeter. Okay, if it is less than 200 centimeter, then you can say the patient has got short bowel. So this is the only keyword to be remember so far is about less than 200. So definitely if it is less than 200 centimeter, so it may even threaten the life of the patient because there will be nutritional deficiency, fluid and electrolyte may be deranged. All these problems may occur. Anyway, the only keyword to remember here is less than 200 centimeter is short bowel syndrome. Only keyword. Now, what are the effect? What is going to happen? Diarrhea. Why? You have removed a part of the small intestine. The bile acid cannot be reabsorbed. Okay, and so they will enter the large intestine and they will have a purgative effect. So especially if the part removed is of distal ileum, okay, so small intestine has been moved, that will hamper the enterohepatic circulation of the bile, and that will lead to purgative effect on the colon. Understood? It will lead to diarrhea. Steatorrhea, again bile acids are not there, okay, and that lead to fat malabsorption. Remember, you remember the basic biochemistry which I discussed about the bile salt in my lecture on pregnancy, the disease of of liver in pregnancy. You can see detail, and there I told you bile acid, they have a 95% they have a enterohepatic circulation. Now enterohepatic circulation is not there, bile is going out, so fat will not be absorbed, that lead to steatorrhea. So diarrhea, steatorrhea are the two keywords, only two keywords, just remember diarrhea and steatorrhea. Gallstone, again super saturated bile will lead to gallstone. So now we are getting second entity today where we got gallstone. And oxalate, this is the most important. You forget the previous three, I don't mind, but this is the most important. Oxalate nephropathy, because of increased absorption of oxalate, because calcium which normally bind to oxalic acid bind to excess of fatty acid. The point to be noted, normally this calcium bind to oxalic acid, but now the plenty of fatty acid is there, so calcium loves to bind to fatty acid. So now oxalate are free, they are absorbed in the whatever small intestine is there, and they predispose to oxalate stone. So only keyword out of the four is oxalate stone, or at the most you can say gallstone. So you can see kidney stone or gallstone are the simplest. The key golden line to remember is kidney stone and the gallstones. Kidney stones, gallstones. Very simplified thing is there. Causes of short bowel syndrome, gastric surgery. They do what? This is the stomach. Okay, what they do? They connect stomach with the intestine, so-called gastrojejunostomy, or especially the stomach is connected to the intestine. They remove a part of intestine and they remove the part of intestine also. Enterocolic fistula, especially from the small bowel, small intestine, with the its straightway goes to the large intestine by the fistula. It bypasses the entire small intestine, or any bowel resection, especially in Crohn disease, or maybe TB of the intestine, or maybe ischemic injury. In this, the part of intestine is removed. Okay. right? So this was regarding the small bowel syndrome. Bacterial overgrowth syndrome. If you look into the word bacteria overgrowth, there will be excess of the bacteria. Okay, so let us see. This is also known as stagnant bowel syndrome. Well, there is proliferation of the colonic type of bacteria within the small intestine. Very interestingly, so large amount of bacteria are there in the small intestine which are proliferating, right? So that's why the word is bacterial overgrowth, excess of bacteria in the small intestine. Causes functional stasis due to impaired peristalsis, classically seen in diabetes, scleroderma. We know very well in diabetic autonomic neuropathy, there can be constipation. So there is no movement of intestine. The food is the food is stasis in the intestine. No movement. No movement. No movement will give you more and more chance of bacteria to grow. Very simple. You are going on the road is jam, whole traffic is there on the road, and people are sitting for hours together. Hours together are there. So what happened? What happened in those circumstances? Just imagine, everybody have experienced this thing, and they all of you are restless, you want to pass urine, etc., etc. Why? Why? Because traffic is jam. Here also the traffic is jam, so bacteria are free to grow. Bacterial overgrowth syndrome. Anatomic stasis, like diverticula. A diverticula has there, food is there, and bacteria is very comfortable in any static condition. Direct communication between large and the small intestine, enterocolic anastomosis, again give a bypass to so many bacteria. Okay. One of the commonest symptoms is unexplained weight loss. This is not known to 99%. Unexplained weight loss. Patient may have diarrhea, maybe steatorrhea, but they are not going to ask. Macrocytic anemia. 99% they will talk about macrocytic anemia. Whenever they will talk about macrocytic anemia, either they will say it is the patient is vegetarian, or some history suggestive of tuberculosis, because TB of the intestine involve the terminal ileum where the B12 is absorbed. Otherwise, bacterial overgrowth. Okay, and I am not talking about pernicious anemia, etc. But if you get a vegetarian, 99% you are dealing with B12 deficiency. TB of the intestine, 99% is B12 deficiency. Okay, so macrocytic anemia, B12 deficiency, because bacteria they consume all the B12 and that lead to B12 deficiency. Treatment is largely empirical. Treat the basic cause, whatever the cause is. If it is a diverticula, whatever it is, treat the basic cause, but it's mainly empirical. Surgical treatment can be done depending on what the cause of blind loop syndrome. So, functional status or anatomical stasis, or there may be direct communication between large and small intestine. Treatment is largely empirical, and the B12 deficiency and unexplained weight loss. They are the two very, very important words that you got to remember. So golden line to remember: patient having megaloblastic anemia, B12 deficiency and unexplained weight loss. Think about blind loop syndrome. Thank you very much. God bless all of you.